So here we're going to go through autonomics of neuroanatomy. We'll talk about the parasympathetic and sympathetic nervous systems, and then some specific functions: micturition, baroreceptor reflex, neural control respiration and GI motility, and finally nociception and pain. This is a general overview of the autonomic nervous system. Parasympathetic nervous system, its basic function is rest and digest. Sympathetic, it's fight and flight. And then these are the key nervous system structures for its innervation. Here are some key targets: heart, lungs, GI system, urinary system, and then the skin. From a parasympathetic nervous system arrangement, there is a preganglionic neuron which uses acetylcholine or acetylcholine, and then there's a postganglionic neuron which is far away from the preganglionic neuron. And then the target is close to the postganglionic neuron, and acetylcholine is the neurotransmitter used both postganglionic and preganglionic, and again the action is rest. From a sympathetic standpoint, preganglionic neuron again uses acetylcholine. The postganglionic neuron is close to the preganglionic neuron, so that's a key difference. And then another key difference is that norepinephrine is the key neurotransmitter that's postganglionic sympathetic. An exception is sweat glands, which again use acetylcholine, and epinephrine for the adrenal medulla. In terms of the target, it's far away from the postganglionic neuron, and again the action is action versus rest and digest. It's fight or flight with sympathetic. So let's go through the parasympathetic nervous system in more detail. Cranial nerves 3, 7, 9, and 10. And then from the spinal cord, it's the sacral level, S2 to S4. These are key functions you can learn on your own. Just want to point out some helpful mnemonic type things. When there's slowing of the heart rate, we block acetylcholine, so we use cholinergic antagonists. If there's bronchoconstriction, such as with the death rattle when we terminally wean patients, again we use cholinergic antagonists. We block acetylcholine. And then for general engorgement, this is always a helpful mnemonic. Parasympathetic is point, sympathetic is shoot for ejaculation. And then this SLUDS mnemonic is helpful. Pay attention that the S is sweating and sympathetic. Here is our neuroaxis here. Again, we're going to be talking about the cranial nerves and then the sacral level of the nervous system. From a cranial standpoint, 3 hits the ciliary ganglia, which and then causes pupillary constriction. 7 hits the pterygopalatine and submandibular ganglia and then innervates facial glands. 9 hits the otic ganglion and innervates facial glands as well as cardiovascular system. And then 10, the wandering nerve, the vagus nerve, innervates via nucleus ambiguous fibers, cardiovascular system, and then it also innervates pulmonary system, abdominal organs, and then the upper 2/3 of the GI tract, the foregut and midgut, and then the upper urinary system. The sacral level, S2 through S4, then innervate. Here we see the inferior hypogastric plexus, but we see innervation to the lower 1/3 of the GI tract, the lower urinary system, and reproductive organs. Sympathetic nervous system, again causing that fight or flight response. Now we're talking about thoracic level 1 through L2. So key innervator within the brain, hypothalamus here. We just show some surrounding structures, the thalamus and the lateral ventricle, and then we see the hypothalamus around the 3rd ventricle here. It innervates via posterolateral hypothalamospinal tract fibers. It innervates this T1 to L2. Now we've demarcated the ciliospinal center budge here from C8 to T2, and then we've demarcated these different 2 levels within that T1 to L2 segmentation. There's this paravertebral chain here, which has cervical, thoracic, lumbar, sacral regions to it. Again, we point out the stellate ganglion, which is named ganglion for the inferior cervical and first thoracic ganglia combined. And then some key structures, vascular structures, carotid artery, and then the descending abdominal aorta, which has prevertebral ganglia. These were paravertebral sympathetic chain, and then these are prevertebral ganglia. And then here are our targets. So superior cervical, across carotid artery, head and neck, and you can learn all of these on your own. But for instance, prevertebral ganglia, celiac goes to the upper GI tract, whereas all the way down here, inferior mesenteric ganglia to the lower portion of the GI tract. Micturition. We have two key tutorials on the site, anatomy and physiology, and then this detailed anatomy. We're going to combine things here to learn core information. Parasympathetic nervous system, as we might imagine, activates micturition. It activates urination since that's part of the rest and digest state. Sympathetic will inhibit it. We don't need to be urinating when we're fighting or flighting. And then somatomotor, which is our volitional control, we have the ability to inhibit urination if we need to. This is the basic setup. This is the target of innervation. So the detrusor muscle, internal urethral sphincter, and then the external urethral sphincter. So when it comes to the sympathetic, what do we think it's going to happen? Well, it's going to inactivate or inhibit the detrusor muscle from activating, and it's going to activate the internal urethral sphincter to block urination. In contrast, the parasympathetic nervous system is going to activate the detrusor muscle to force urination. It's going to block the internal urethral sphincter to open things up so the urine can come out. From a somatomotor standpoint, it's going to activate the external urethral sphincter for volitional control. Again, some key anatomy here, descending aorta, and then the neuroaxis here with two key spinal levels we pointed out. And then we have our bladder, vesical ganglia, and then our internal and external urethral sphincters. Note that the vesical ganglia causes activation of the detrusor muscle and inhibition of the internal urethral sphincter. So, sympathetic innervation, coming down, activating T12 to L2, and look at what it does. So it causes inhibition of the detrusor muscle, and it causes activation of the internal urethral sphincter. It also inhibits the vesical ganglia to produce the same effects. Then from a parasympathetic standpoint, when we want to have micturition, we activate the detrusor muscle and we inhibit the internal urethral sphincter. And then onus nucleus S2 to S4, this is the somatomotor region that allows us volitional control, and it's activating the external urethral sphincter. Baroreceptor, again, we have two tutorials in this section, detailed anatomy and then just anatomy and physiology. We're going to combine things again for our purposes here. Some key definitions: mean arterial pressure is cardiac output times total peripheral resistance. Cardiac output is stroke volume times heart rate, really core to physiology. And then total peripheral resistance is a definition of arteriolar constriction. So here's our heart, and then here's our baroreceptor and the arch of the aorta, and then here's our carotid sinus and along the internal carotid artery here. Some other key structures, brain and medulla. So just very quickly, parasympathetic nervous system, think about the solitary tract nucleus within the medulla, this cardioinhibitory center. And then from a sympathetic standpoint, think about the vasomotor area in the medulla. And again, sympathetic to T1 to L2 here. So parasympathetic is going to cause decreased heart rate and contractility. Again, it's a rest state. Sympathetic, on the other hand, is going to cause increased heart rate and increased contractility. So walking through this anatomy and physiology, we can think about when a person's bleeding out or there's acute hypotension, dehydration, loss of volume. If there's a loss of volume, there's going to be a loss of mean arterial pressure. There's going to be a reduction in baroreceptor stretch. There's going to be a reduction in baroreceptor activity, a reduction in cranial nerve 9 and 10 firing, which is up here. And thus, there's going to be a reflex. There's going to be increased sympathetic activation, reduced parasympathetic activation. This is going to increase contractility and ultimately stroke volume, increased heart rate, venous constriction. All of these things will increase. This is a compensatory response, which is going to increase cardiac output and increase total peripheral resistance. Neural control of respiration. Brainstem mediator of respiration, dorsal respiratory group, think solitary tract nucleus, sensory integration. Ventral respiratory group, think motor output, nucleus ambiguous. And then really, really important, C3, C4, C5, keep the diaphragm alive. Different breathing patterns in regions of injury, really helpful for localization. If you're just watching a patient, be it drowsy or comatose, watching their breathing pattern can help you localize the site of the injury. Supratentorial cortical injury can cause this Cheyne-Stokes response, and here we see a diagram of the breathing pattern that you see in Cheyne-Stokes respirations, these pauses in breathing with a flattening. And then at the midbrain region, and this is a loosely localizing sign here, there can be this severe hyperventilation response. Apneusis, these long inspiratory stretches here with injury to the upper pons here, you can have apneusis. And then lower pontine, upper medullary injuries can cause this cluster breathing here, this clustering pattern. And finally, lower medullary, the most worrisome pattern of all of these, is this ataxic breathing pattern, totally irregular here. Some key anatomy here we won't go into beyond what we've said over here. And then just some key respiratory mediators. So there's the inspiratory muscles, these secondary muscles. Again, this cranial 9, 10, 12 innervation here. And then the carotid bodies, arch of the aorta, aortic bodies here, providing information about oxygen, carbon dioxide, and pH levels. And then ultimately, of course, C3, C4, C5, keep the diaphragm alive with phrenic nerve innervation of the diaphragm. And then these intercostal muscles are very important for respiration as well. And really what we're hammering home here is that there's a neural control of breathing. So not all patients with dyspnea have pulmonary problems. They can have brainstem injuries, for instance, or they can have neural muscle disorders that are causing dyspnea. And the way that you manage those patients is going to be quite different than a patient with a pulmonary issue. Neural gastrointestinal system, there's an intrinsic activation or innervation of the GI system, and then there's extrinsic. Extrinsic is what we've been talking about. Intrinsic we'll introduce here. There's two key nerve plexuses within the intrinsic GI nervous system. The Meissner's plexus, the submucosal, and then the myenteric Auerbach's plexus. And we'll show these here. So here's the submucosal Meissner's plexus here, and then here's the myenteric Auerbach's plexus here within this muscularis layer right here. And then this is this extrinsic control. We've talked about parasympathetic is going to promote contractility, whereas sympathetic is going to inhibit contractility. So let's talk about some key neurotransmitters and drugs that are going to affect the GI tract and how they'll do it. As you can imagine, acetylcholine is going to increase GI motility. Remember, we said that it was the mediator of parasympathetic postganglionic fibers. So amitriptyline, which blocks acetylcholine, is going to reduce GI motility and increase constipation, whereas donepezil is going to increase acetylcholine. It's a cholinergic agonist, and so it's going to increase GI motility and have potential cause diarrhea. Norepinephrine, the postganglionic sympathetic mediator, is going to reduce GI motility. So beta blockers can block norepinephrine, so they're going to increase GI motility, have potential cause diarrhea, whereas venlafaxine, for instance, is going to increase norepinephrine. It's going to reduce GI motility, and it can cause constipation. Opioid peptides will reduce GI motility, and we'll talk about opioids when we talk about nociception and pain next. And finally, serotonin, and this is where it gets confusing with the antidepressants because they have an admixture of norepinephrine and serotonin, but it will increase GI motility And so you can see these various, so quetiapine, for instance, which reduces serotonin, is going to reduce GI motility, whereas citalopram, which increases serotonin, is going to increase GI motility. Nociception and pain, our final topic here. Key definitions. So nociception is the detection of a noxious, a harmful stimulus, whereas pain is the psychological response to a noxious stimulus. So here's our core anatomy right here, dorsal root ganglion, dorsal root, activating a neuron in the dorsal horn here, and then we have an interneuron and a modulatory innervation as well. This is the setup for the pain system here. We see our noxious stimulus here. So how can we control this? Well, an opioid receptor can directly inhibit the noxious stimulus itself. There can be inhibition of this presynaptic neuron, such as from inhibition of calcium influx, so there isn't activation of this. There can be promotion of hyperpolarization, a reduction of activation of the postsynaptic neuron. That's another thing opioids can do. And they do it through promotion of potassium efflux. And then there can be disinhibition of modulatory pain pathways. So here, this modulatory innervation is trying to block the receptor, but it's naturally inhibited, so it needs to be disinhibited in order to create its analgesic effect. And this is just to point out, this is this modulatory innervation that we're talking about, and then this is this interneuron here. Finally, we discuss in this tutorial these key opioid receptors and their neurobiology. So that's a primer on autonomics of neuroanatomy. A lot of key clinical pharmacological correlations to learn in there, and then understanding this core difference between sympathetic and parasympathetic innervation is really fundamental to the practice of medicine.